Good morning, everybody in Ocala. Good morning, everybody around the world that's watching today's program. This is a Compass to MS Care program provided only by MS Views and News. All right, and today's program, our sponsors that support this program are Genentech, Banner Life Sciences, and Bristol-Myers Squibb. Let's give them a round of applause. Thank you. All right. I hope that for those that are here that you got to go around to the different tables and see who was sponsoring today, who was the display sponsors rather, and those were Genentech, Banner, Alexion, Bristol-Myers Squibb, and TG Therapeutics. I'm sure they all had plenty of good information to give you. For those online, if you need to find out about it, you could go to each of their websites. Today's program, again, it's a Compass to MS Care program. My name is Stuart Schlossman, president and founder of MS Views and News. Been doing this for quite some time. And we have Dr. Kalina Sanders from Jacksonville. Dr. Sanders is going to be speaking today about MS treatment options, spasticity, pain management, access to care in rural America. She's board certified neurologist at Baptist Neurology, and she's been in practice for over 12 years. I know that we've had her speak in the past. Unfortunately, not enough, but I am going to remember to do this. So let's welcome Dr. Sanders. Thank you.
Well, it is a pleasure to be here today. I was actually here with MS Views and News about 8 years ago, right? 5 years ago, actually, in 2018. And at that time, the program was going to be recorded and uploaded onto YouTube. And I joked and I was excited about becoming a YouTube sensation. Unfortunately, 5 years later, I have not met that goal, but I am equally excited about sharing my knowledge, my insight, and educating patients with multiple sclerosis and their family members. So with that, I'm going to go into my presentation. So our approach to multiple sclerosis has really evolved over time, and we are now really approaching MS in a comprehensive, holistic approach. And that really includes the use of disease-modifying therapies, which is not on this slide, as well as symptomatic treatments, which are really meant to help to decrease your symptoms, improve your quality of life, and it is also integrated with wellness and lifestyle modifications, which are just as equally important as our disease-modifying therapies, our symptomatic treatments. So I can stand here today saying we are almost 30 years after the approval of our first disease-modifying therapy. Beta-Seron was FDA approved in July of 1993. And if any of you were diagnosed at that time, you may have been experiencing with or familiar with the lottery. And at that time, the patient had to be chosen for the therapy. Over the next 30 years, as you can see in this timeline, we have made great strides at increasing the number and the types of disease-modifying therapies. So here in 2023, you get to choose what therapy works for you. Over the next few slides, I will talk about the disease-modifying therapies. I will not go into a lot of depth about the clinical trial data because we would be here for 2 days if I did that. We now have 20 approved therapies. And like you, I also want to hear Jeff's advice and recommendations about our lifestyle modifications. But it's wonderful to see this timeline of our disease-modifying therapies that are there to help modify the disease. So I like to discuss the disease-modifying therapies by the route of administration. So I'm going to start off with the injectable medications. We have our interferon beta-1b medications, which are Beta-Seron and Extavia. These are self-injections that are given subcutaneously every other day. Then we have interferon beta-1a. Avonex is an intramuscular injection given once a week. Rebif is a subcutaneous injection given 3 times a week, and it actually has 2 doses, 22 micrograms and 44 micrograms. And then we have Plegridy, which is a subcutaneous injection given every other week. Another notable injection is glatiramer acetate, which has 2 doses, 20 milligrams once a day, 40 milligrams 3 times a week. And then lastly, our newest injectable medication is ofatumumab or Kesimpta. That's also self-injected monthly. In 2010, we got our first oral therapy, Gilenya. And since then, over the last 12 years, we now have 9 oral therapies approved for the treatment of multiple sclerosis. We have Gilenya, Mayzent, Zeposia, and Ponvory, which are in a class that we call S1P modulators. These are given once a day as an oral pill. Teriflutamide is also a daily oral medication, or Aubagio, it's its brand name. And then dimethylfumarate or Tecfidera, diroximel fumarate, and monomethyl fumarates, or I like to classify as our fumarates. Those are given orally twice a day. And then there's cladribine. Cladribine is given as short courses on a yearly basis. So depending on a person's weight, they could take 8 or 10 tablets in the first year, and then that is also repeated in the second year. And then we have our infusions. We have natalizumab or Tysabri, which is given once a month. We have alemtuzumab or Lemtrada, which is given yearly. The first year you get 5 days of an infusion. The second year you get 3 days of an infusion. And then we have ocrelizumab or Ocrevus. That is given every 6 months. And our newest kid on the block, I like to say, is ublituximab. Say that 10 times. Or Briumvi. That one's still hard to say. And that is an infusion that is also given every 6 months. I do have mitoxantrone or Novantril on the list, and that is still FDA approved for the management of multiple sclerosis, but we don't use it any longer due to the toxicity of it. So in this day and age, I think it's also very important to highlight and talk about generics and bioequivalents. We have several disease-modifying therapies that now have either a bioequivalent or a generic. And so I wanted to spend a couple of moments really talking about how the FDA addresses and approves these therapies. So when we think about all of the disease-modifying therapies I just went through, those are approved through a new drug application. It's under one category in the law called 505(b)(1), and they are required to go through several stages or phases of clinical trial research, phase 1, phase 2, phase 3, and prove through those clinical trials effectiveness and safety of their therapies. They then submit their application to the FDA, and then they get their approval. This process can take upwards of 9 to 12 years to go through all of that process to get it approved. Now, for our medications that are bioequivalent, these are also go under the new drug and application, but these are under a different process. This is through a 505(b)(2), in which they do have to prove some effectiveness and safety of their product, but they can also use the data from the originator medication. And so the two examples of those bioequivalents are Vumerity and Bafratam, the fumarates. Now, we do now have several generic medications as well. Those are approved through a different pathway called an abbreviated new drug application. They are not required through this application to prove their individual drugs' effectiveness or safety. However, they do have to show that they are pharmaceutically equivalent to the brand drug, that the manufacturer is capable of making the drug correctly and consistently, and that their active ingredient is the same as that of the brand. The right amount of the active ingredient also has to get to the right place in the body to have its effect. And then they also have to approve that their inactive ingredients of the drug are safe. Okay, so examples of that, generics are Glatopa, glatiramer acetate, dimethyl fumarate, and fingolimod. So they are approved through a different pathway, but have been proven or shown to have pharmaceutically equivalence. Okay, so how do these drugs work? I have here in this picture really what we think happens in multiple sclerosis. So in patients who have MS, it's considered an autoimmune disease. And so the immune cells, particularly the T cells and the B cells, are activated. This activation usually occurs in the periphery, outside of the nervous system. They then have to cross the blood-brain barrier through the bloodstream and enter the central nervous system. So the way our medications work, they work by modulating or changing the immune system. So depending on the agent, and this picture kind of describes what we see, our S1P modulators, and I'll remind you, that's Gilenya, Mayzent, Ponvory, and Zeposia. They work by sequestering or keeping your T cells and B cells in your lymph nodes. That way, they are not circulating in the bloodstream, they're not crossing the blood-brain barrier and going inside of the central nervous system. Other agents that I've mentioned include teriflunomide and cladribine. This is Aubagio and Mavenclad, and then this is Lemtrada. They work differently to decrease either the activity or the quantity of our T cells. So particularly teriflunomide or Aubagio, it prevents those activated T cells from replicating, okay? And so you don't have as many T cells activated in the periphery, crossing the blood-brain barrier, and entering in the central nervous system. Medications like Mavenclad and Lemtrada, they do decrease both T cells and B cells, so they decrease the amount of cells that are available. But then those cells are allowed to repopulate. We call those immune depletion followed by repopulation medications. Then we have our fumarates, our interferons, and our glatiramer acetate. They change how those T cells function in our periphery. Particularly the glatiramer acetate works by tricking the immune system and forcing it to have more anti-inflammatory T cells versus pro-inflammatory T cells. The fumarates work on this pathway called the NRF2 pathway. And I like to think about that as an antioxidative pathway. So they create an environment that don't allow proactive or inflammatory T cells to flourish. And then our interferons also work with this shift between anti-inflammatory T cells, which there are, and pro-inflammatory T cells. And then we have natalizumab or Tysabri. It's unique in that it actually doesn't affect how the T cells and B cells function or the amount, but it has an impact on how those cells cross the blood-brain barrier. So it prevents those activated T cells from attaching to the blood-brain barrier, which is necessary for them to enter into the central nervous system. I like to think of Tysabri as a glove on the hands of our T cells and B cells. When they try to attach to the blood-brain barrier, they can't, and so they keep flowing. And so as a group of disease-modifying therapies, they have been, in clinical trials, proven to have some effectiveness. Most of our disease-modifying therapies, all of our disease-modifying therapies are approved for relapsing forms of multiple sclerosis. That includes relapsing remitting MS and active secondary progressive MS. Most of our disease-modifying therapies also are approved for patients who have clinically isolated syndrome. Those are the patients that have their first bout of disease activity. That might be their first bout of optic neuritis, but they've not had time to go on to develop clinically definite MS. And in the clinical trials, our agents, depending on which one, were studied against placebo or a sugar pill, or they were studied against an active agent. And that may be another FDA-approved disease-modifying therapies. But in the clinical trials, they really showed 3 benefits. They showed that they reduced the likelihood of having relapses, or what we call an annualized relapse rate. They also have proven to decrease MRI activity. That may be new T2 spots or white spots on the brain. That may also mean that they have an impact on overall brain volume, and then disease activity or active disease activity such as enhancing lesions. And then they have all shown some benefit with reducing the likelihood of having disability progression over time. Again, as I mentioned before, I won't bore you with all of the scientific details of the clinical trials, but that is the gist of what they were proven and what was necessary for the FDA to approve them for our use. So disease-modifying therapies are important. I have highlighted how they work, but I want to stress the importance of the impact they have on long-term disability in patients with MS. Now, obviously, I mentioned before, we're only 30 years into our disease-modifying therapy approvals, so we have a lot of natural history data. So if untreated multiple sclerosis, good thing it wasn't looking. If untreated, we know that our patients will transition into secondary progressive MS and accumulate a lot of disability. If left untreated, about 50% of patients at about 10 years will require the use of a cane to ambulate. And if you take that out to 20 years, that jumps up to 90% if left untreated. But with early diagnosis and intervention, so if we start disease-modifying therapy at the time of diagnosis, we know that we change the course of the disease for the group of people. Now, I always like to highlight that within these graphs are individuals, so that your journey with multiple sclerosis may not be what we show in the picture. It's really what we describe as a group effect. So in patients who are on disease-modifying therapy at the time of diagnosis, we do a very good job at decreasing the amount of overall disability over time. Now, in some patients who were diagnosed but opted not to or did not have the option to start a disease-modifying therapy, we know if we start it later on, we still have an impact on the amount of disability that they accumulate over time, but it's not as well as if we do early diagnosis and early intervention. But I like to tell my patients that this is really a snowflake disease, right? There is no 2 MS patients that are alike, that there is a spectrum of the disease. And there are going to be people at the milder end of the spectrum that will do well regardless of what you do or not do. And there are going to be people at the other end of the spectrum that will do poorly despite everything that you do. Most people with multiple sclerosis are somewhere in the middle, but we know that as a group, if we start intervention early on, people do better. So how do you decide which one of these medications that you are a candidate for, or something that is an option for you? It really starts with a conversation that you have with your healthcare provider. There are a number of different qualities about the medications that your healthcare provider will know and understand. There are things or qualities, characteristics of your disease activity that your healthcare provider or neurologist will also understand. So we have to take into account those treatment goals, right? What is the goal from a physician standpoint or a neurologist standpoint, knowing the disease activity, knowing the qualification or the criteria of our medication, but it also involves your treatment goals. What do you have in mind for your future or your health in multiple sclerosis? And that shared decision-making and communication is very important. How do you do that? You educate yourself. You come to events like this, you view us from online, and you learn about all of the different aspects of multiple sclerosis and our treatment, and you take that with you to your office visit, and you discuss those things with your healthcare provider. You also want to discuss with your healthcare provider your desired routes of administration. There are some people that are completely needlephobic and will never ever take an injection, but the healthcare provider needs to know that that is not an option for you, because that helps us to make that decision. We also need to take into account convenience. Maybe you are a young working mother that doesn't have a lot of time on their hands, doesn't have the ability to manage injections, or don't have enough time to take an oral therapy every day. Or let's say that you travel and you don't have the means to take these medications or different types of medications with you. So that needs to be taken into account when you are choosing your disease-modifying therapy. Now, I previously talked about the effectiveness of the medications and how well they did in the clinical trials, but they also come with potential side effects and adverse reactions. So that discussion also needs to be had with your healthcare provider, and they need to understand your level of risk tolerance. So for one person, they may be able to accept the possibility of PML, but for someone else, that's not an option. So that is also should be taken into account when you are discussing with your healthcare provider your preferable disease-modifying therapies. We also need to look at your comorbidities, and that can change over your lifespan. So this needs to be reevaluated over time. There are certain medications that have an impact on the way the heart functions, or they have an impact on their liver functions. And so those types of things need to be understood when making that decision. And then the elephant in everyone's office or exam room is the insurance coverage. Sometimes that can dictate what therapies might be feasible for you to obtain. However, I always like to say to my patient, where there is a will, there is a way. And so if we, as a partnership and a team, decide X medication is for you, we will work very hard to make sure that we get that medication for you. So when a person is diagnosed with multiple sclerosis, and I kind of alluded to this in the previous slide, there's really things that come into play over the course of a person's journey. So we might make our first disease-modifying therapy selection, but then we need to monitor for disease activity. We also need to monitor for safety and tolerability, as well as some lifestyle changes. So at any point, if there is unstable or a suboptimal disease response, we might need to discuss what the next disease-modifying therapy is. But if the disease activity is stable, we can continue there. Or let's say someone is planning to become pregnant and their current disease-modifying therapy is not appropriate or unsafe in pregnancy. We might need to, again, start to think about sequencing or changing disease-modifying therapies. So over the course of the disease, this is all of the things that we are thinking about, is whether or not we are controlling the disease activity, whether or not the medication is safe and you are tolerating it, or whether or not your lifestyle accepts a disease-modifying therapy like that, and then we make our changes. But over the time, we are monitoring disease activity and monitoring for safety. So I mentioned that all of our disease-modifying therapies are approved for relapsing forms of multiple sclerosis, most of them including clinically isolated syndrome and active secondary progressive MS. But what about primary progressive MS? So we currently have one FDA-approved agent for patients who have primary progressive MS, and that is Ocrevus. But there is a lot of medications and treatment options that are undergoing investigation right now. There is a newer class of medication that is under clinical trials as we speak, and they're called BTK inhibitors, or Bruton tyrosine kinase inhibitors. And these are two examples, and bear with me, I think it's tolobrutinib and fenebrutinib. We'll see what their brand names are. But they are undergoing, so tolobrutinib is undergoing 2 clinical trials looking at primary progressive MS and non-relapsing secondary progressive MS. And then fenebrutinib is looking at an active comparator in patients with primary progressive MS. The tolobrutinib study is slated to end around 2024. Fenebrutinib is going to probably end around 2028. So they're not on the cusp of approval, but definitely undergoing investigation. And how do these work? So the BTK inhibitors really kind of have 2 effects. One effect is on the B cells, or the precursor cells that form B cells, so they have their impact here. But interestingly enough, BTK also has an impact inside of the central nervous system, and it works on one of the nerve cells called microglia. And it is felt that its impact on microglia is probably what is helping or exerting its effect on progressive disease. So this is very exciting news, and look to see for more information about these agents in the future. So what do our disease-modifying therapies not do? So we know MS is a demyelinating disease. We also know that our body has the ability to remyelinate or repair some of that damage. But we also know that MS is an axonal loss disease as well. So what do our disease-modifying therapies not do? They currently do not help to promote remyelination, and they do not prevent axonal loss or repair axonal loss. And we also know that our therapies are not cures for MS. And so because of that, you may or may not have symptoms related to your multiple sclerosis. Now, I could spend another 2 days talking about all of the symptoms of symptoms that come along with multiple sclerosis, but I'm going to focus primarily today on spasticity and pain. So spasticity is a spectrum of symptoms related to increased muscle tone or the stiffness of the muscles. It can be as simple as just a feeling of stiffness. They don't move as well or as quickly as you like them to move. Or the spasticity can involve involuntary spasms. And those involuntary spasms could be extensor spasms, where your legs and your arms extend out and you have difficulty bending them. Or the spasticity can come when your legs are contracted or bent. We call those flexor spasms. Now, for spasticity that involves the upper extremities, for the most part, it involves muscles that flex the arm. That's why I brought in this picture here, because this is a common end-stage effect of spasticity. The elbow is bent, the wrist is bent, the fingers are bent. Those are all flexors in the upper extremity. But in the lower extremity, spasticity seems to affect the muscles that extend the leg. And so that's why you may walk with what we call a peg leg. You have difficulty bending at the knee. You have difficulty bending at the ankle. And those are the muscles that are involved because it is a central nervous system problem. Now, when spasticity is severe, it can result in contractures. When you have contractures, the muscles no longer are able to activate and move because the joints are frozen. So if you've ever known someone to have a frozen shoulder and they can't move it, over time, if spasticity is left untreated, those joints in the fingers and the toes and the legs can become stiff and frozen, and they don't move even if the muscle wanted to. So how do we manage spasticity? Spasticity is fairly common in patients with multiple sclerosis. Up to 80% of patients experience some sort of spasticity. That can be mild, like those brief spasms I talked about. It can be, again, the flexor and the extensor spasms that can impact mobility. So our goals of managing spasticity obviously is to improve your function, your ability, and your independence. We want to keep you moving. We want to keep you ambulating. We also want to decrease pain associated with spasticity as well. And then we also want to prevent or decrease the occurrence of contractures. So those contractures can be prevented with adequate intervention. And then we also want to be able to ease your rehab potential. So I think it's also important to know that there are certain things that can worsen spasticity. So we want to be able to identify and avoid those triggers. What are those? Extreme temperatures. So many of you are familiar with when the temperature increases, you become overheated, your symptoms get worse. That includes spasticity as well. Humidity, living in Florida, can increase your spasticity. Also, sudden movement. So if you try to get up too quickly, your leg doesn't go. But if you take your time to change positions, then it moves well for you. That's spasticity. Tight clothing can worsen spasticity as well as infection. So what are some things that can be done? Jeff's going to talk about in a little bit the role of exercise and physical therapy in the management of these symptoms. So stretching, I encourage my patients to stretch multiple times a day, but definitely morning and nighttime. But if you can fit any other periods of stretching in there throughout the day, you will find most beneficial. Range of motion exercises, also some weight bearing exercises can be helpful, as well as pool therapy. So aquatics is a great way to combat imbalance or weakness and get those muscles moving. So I encourage that. And if you can, aerobic exercise, EMG feedback is another physical therapy modality that can be used to help to activate muscles and allow them to stretch. And then electrical stimulation. Now, if you're doing all of that and still are having significant amount of spasticity, there are some therapeutics that we can use to help to decrease the tone in your muscles. So there are oral therapies. Most commonly, we will use baclofen, tizanidine, or Flexeril. There are some other types of medications like our anti-epilepsy medications, that's gabapentin and Tegretol, that can be very helpful, particularly with those very quick extensor spasms that a person may have. Other medications that have been tried and found to be beneficial in some people include Sinemet, which is actually a Parkinson's medication, but can be helpful in certain individuals who have significant spasticity. Now, if you have focal spasticity or spasticity in one or two muscles, Botox injections is FDA approved for the treatment of upper and lower extremity spasticity. However, we are limited in the amount of Botox we can use, and so we tend to target areas that are mostly effective. Botox generally takes effect within 1 to 2 weeks after the injection, and for most people, Botox is effective for 2 to 6 months. So it is a treatment that will require recurrent treatments and injections. Now, if you have severe spasticity, despite the use of oral therapies, despite physical therapy, there is a intrathecal baclofen pump. Intrathecal means it goes directly into the spinal canal or spinal fluid. But it is a way for us to give your body baclofen right where it needs to be. It goes inside as a liquid, so it bathes the nerves and it allows them to decrease in their tone. This is more helpful when you have more generalized spasticity or spasticity that involves both of your legs and some of your arms. It allows us to give you a much smaller dose of baclofen than we do in the oral pills. So when we talk about the dose of baclofen, if you think about your dose, you may be taking 10 milligrams or 20 milligrams. When we talk about the dose of the baclofen pump, we're talking micrograms, right? So there are 1,000 micrograms in 1 milligram. And so because it is targeted right where it needs to be, oftentimes we only have to use 50 or 100 micrograms. So that's not even 1 milligram of what you're taking in orally. And it also helps to avoid some of the systemic side effects that you might get with oral baclofen. If you're familiar or if you take it, oral baclofen can make you sedated, or it can affect your bladder function. So we are sometimes able to avoid some of the systemic side effects with the use of a baclofen pump. Now, these therapies can also be used in combination. So in someone who has a baclofen pump and still have focal spasticity, we can target those individual muscles with Botox, or we can use oral medications as needed on top of that. So one of the good things about our management of spasticity is that it can be tailored to whatever your needs are. All right, let's switch gears to pain. Now, historically, it was felt that MS did not cause pain. How many people heard that by their doctors say MS doesn't cause pain? We now know that it does, and it impacts upwards of 40 to sometimes 50% of patients with multiple sclerosis. Now, the type of pain that a patient experiences is different. So there's really two types of pain receptors that our body has. It has our neurogenic, which are triggered by the nervous systems. The nerve causes the pain. And then there is nociceptive pain. That is pain that's generated primarily by the musculoskeletal system. So your muscles are stiff and painful, your joints are stiff and painful. But they both contribute to the pain that patients experience in multiple sclerosis. So some examples of that neurogenic pain may be trigeminal neuralgia, okay, or what some people like to call sciatica, where that pain is radiating down into the leg. Optic neuritis is a painful condition. That's neurogenic pain. And if you have a spinal cord lesion, you might experience Lhermitte's phenomenon. If you bend your neck forward, you get this shooting pain down your spine and extremities. Those are all neurogenic pain. The nociceptive pain, as I mentioned before, could be muscle spasms in the back, stiffness in the joint, or other musculoskeletal pain. So how do we treat pain? If it's neurogenic, we do have medications that impact the transmission of pain along the nerve fibers. Oftentimes we will use anticonvulsants or anti-seizure medicines, most commonly gabapentin or pregabalin, also known as Lyrica, and carbamazepine. Now, some antidepressants are also helpful with pain, and those are generally our tricyclic antidepressants like amitriptyline, if you've heard of that, nortriptyline, but there are others such as duloxetine or Cymbalta that can be helpful for neurogenic pain. And then cannabinoids can also be helpful for neurogenic pain. Now, if it's more nociceptive or musculoskeletal, then we're looking at our NSAIDs. That's our ibuprofens and naproxens. And then we also want to target and treat your spasticity. So if we can relax your muscles, that will ease your pain. And then physical therapy is also very helpful for more of the nociceptive pain. It may or may not help your neurogenic pain, but it can help your pain overall. And then cognitive behavioral therapy can be helpful. And then lastly, I'll highlight, and I'm sure Jeff is going to touch on this in our next talk, is maintaining a healthy lifestyle and activity. And just like spasticity, all of these treatments can be used together. So we want to make sure that you're staying physically active and exercising. We do want to make sure that you're using NSAIDs if you have focal joint pain. And then if we need to, using some of our other neurogenic therapies. All right, I'd like to switch gears now and really talk about access to care and really focus on the rural American and the underserved community. Before I talk specifically about these communities and patients with multiple sclerosis, I would like to touch on a concept or an idea that is ever evolving, and this is this concept of health determinants. And these are non-medical events or characteristics or other definable factors that bring about change in health. So this is separate from the pathophysiology and the makeup of the disease, but really looking at other aspects of a person's life and how those things impact their health and their disease. So we are talking about income and social status, educational level, physical environment, that's where you live and where you work, your social support networks, genetics and sex also comes into play, and then access to quality health services. And when these health determinants are impacted or have an effect, this results in health disparities and health inequalities. So let's talk about rural America challenges. So in patients that are in areas that are not close to an urban or a metropolitan area, there is a lack of physician and specialty availability. There was a survey that asked, I think, 1,500 patients who lived in rural counties across the country, what was their experience with their health care? And these are MS patients. 66% saw a neurologist in the previous 12 months. So that's about a third of people that have not seen a neurologist. 51.6% responded that they did not go to see, those who did not see a physician or a neurologist, 51% said that no one existed in their area. And that the average distance to see a specialist for these rural Americans was 103 miles. So you can see where in rural America, particularly from a neurological standpoint, their access to quality neurological health care is voided. So many patients are seeing their primary care doctor for their management of their multiple sclerosis. They also found that there were lower levels of satisfaction with the access to the neurologist in patients who lived in rural areas. And then they were also noted to have significant lower ratings of the quality of routine care. And that is because they were generally being seen by their primary care physician and not an MS neurologist. When we look at the underserved communities, and these are oftentimes communities of color, so communities where predominant members are African American or Hispanic. In another survey looking at about 900 of those patients, 56% of them said they never saw a neurologist that specialized in MS care. They also looked at other ethnic groups as well. 50.4% of white Americans in that area also did not see a neurologist that specialized in MS care. But as you can see, more of African American and Latino Americans did not see a MS specialist. And 36.8% of African Americans received care in an MS community. So again, 2/3 of patients who have MS are not being seen in MS clinics. And as I mentioned in the earlier slide, we are looking at the approach to MS as a comprehensive approach, knowing and utilizing our disease-modifying therapies, our symptomatic therapies, and our lifestyle modifications. And so having a healthcare provider that understands this comprehensive approach is extremely important. African Americans in this underserved community, 64% were less likely to use case management or social services, and 48% were less likely to use nursing services. Why does this happen? And it drew us back to these social determinants of health. What is it beyond the disease course that affects these patients with MS? So in patients in the rural and underserved communities, they are fraught with lack of transportation. I mentioned the average distance to see a neurology specialist for someone in rural America is 103 miles. And if you are unable to drive and don't have a care partner or someone to help you, to assist you drive, you don't have the access to get there. That is similar in underserved communities. They may not have the distance, but there may be lack of public transportation or the ability to even get across town to their neurologist. These patients, particularly in underserved communities, are more likely to be uninsured or underinsured, which again impacts access to quality neurological care. And that is because of income deficiencies as well as low health literacy. These are just a few of the things that impact access, particularly in these underserved and rural communities. So one way in addressing some of these issues, the National MS Society is a project called Project ECHO. And this is a project that increases the capacity of neurologists and other healthcare providers to diagnose and manage individuals with multiple sclerosis. It is a dynamic professional learning environment where there is a hub of an academic center that are spread out across the country, and then they reach out to individual neurologists or other practitioners that desire to know and learn more about MS. That might be your primary care doctor in a rural area, and they are educated over I think a 14-week period with different didactics and case presentations so that they become more familiar with the options that are available. So they document that this is a high-yield learning experience that promotes collaboration between these academic facilities and general neurologists. So in conclusion, I've highlighted the ever-evolving and increasing landscape we have of our treatment options as it relates to disease-modifying therapies. There remains ways to improve quality of life for patients, particularly when it comes to symptomatic management. But we must assess and address social determinants of health to improve access to care, and then work to improve access to care and provider availability. So with that concludes my presentation. Thank you again for your attention.
Thank you very much, Dr. Sanders. Way to go. Okay, now, how many hands are going up to have a question?
Now, I even wrote it down so it would be just right. Some neurologists have told their patients that as they age, their immune systems weaken. At that point, the doctors suggest patients quit taking their disease-modifying treatments or perhaps change meds. What are your feelings on that?
That is an excellent question, and I get it all of the time. And my general response to my patients is I look at MS therapy as a risk-benefit ratio. So we have to, at any point in your MS journey, assess whether or not what we're doing, whether or not the benefit outweighs the risk. And so there is increasing evidence and thought of immunosenescence, and that's the term for when your immune system quiets down as you get older. And we do feel that that happens for the majority of people. There was one recent study that showed some preliminary data called DISCO-MS, and in this study, they looked at patients who were 55 and older who had stable disease, and they took half of the patients off of their medication. The other half were able to remain on their disease-modifying therapy, both groups stable. Over the course of the study, both groups did have relapses. There wasn't very many, maybe 10 relapses over the course of the study. However, they did find that there were slightly more relapses in the group that discontinued their medication compared to the ones that did. Now, it was not statistically significant, so they could not make definitive recommendations from that study. But what that study highlights to me, and what I described earlier, is that when we look at the numbers, when we look at activity, we look at it as a group, but within that group are individuals, right? And everyone is different. And so my practice is really to assess each individual, look at their disease-modifying therapy, look at whether or not the potential benefits are outweighing the risk, and that includes safety, tolerability, financial impact, and if that scale teeters in the wrong direction, then we have a discussion about either discontinuing or switching to a different agent.
Thank you.
Thank you very much. That it answers one question I had for you. And this one, I have a baclofen pump that I have had for 15 years. It stopped working, and it's all froze up. I tried to have it removed. Just want to let everybody know, you can't have it removed because nobody will remove it. And I've tried everybody because I guess whoever put it in has already been paid to take it out, kind of like your sutures. And that was done in another state. So the baclofen pump worked for a time, and now not. Now it's frozen. Just to let you know.
Thank you. All right, we have questions from online that I'm going to ask as well, and there are questions still here. So the first one online is somebody's asking about the baclofen pump. How is it installed?
So when a person is considered to be a candidate for a baclofen pump, the first thing we have to do is a trial to see if it even works. And so that trial involves doing a spinal tap. And in that spinal tap, we're injecting a bolus of medication into the spinal fluid. We remove the needle, and then we look at your spasticity over the next 3 to 4 hours. And if we see a significant decrease in your tone, that would suggest that you are a candidate for the pump. Then it is implanted by a surgeon or a pain management physician. And that involves putting a catheter into the spine, threading it underneath the skin, and connecting it to what we call a reservoir. That is what holds the medicine. That sits into a pocket underneath the skin. And the pump works by slowly giving baclofen over time. So the implantation is a surgical procedure. Historically, it was an overnight stay in the hospital. Probably post-COVID, they try to get you out as soon as possible. But it is a surgical procedure for that.
Thank you. Another question from online. Shannon wants to know, what are your thoughts on Lemtrada?
So Lemtrada is one of our FDA-approved medications for relapsing forms of multiple sclerosis. It is felt to be a very effective or a high-efficacy agent, and it significantly impacts the disease process, decreases relapses and MRI activity. We do have to weigh its benefits with potential side effects, and that includes other autoimmune conditions such as thyroid disease, kidney disease, and it does require monitoring over the course of the administration years as well as up to 4 years after your last dose. So I feel that there is a right medication for each patient, and Lemtrada is considered to be one of the options that are available.
Thank you. Another one online, Maurice wants to know, what is in the future for PPMS medications?
Yes, so I highlighted that in the slides, and so one of the things that I mentioned there was the use of a newer, novel class of medication called BTK inhibitors that have an impact inside of the central nervous system on microglia, and we have a lot of optimism that it will be effective in progressive disease, including primary progressive MS. A lot of other research is out there as well and ongoing, looking at, and I mentioned earlier, repurposing medications that may help to promote or help to facilitate remyelination, which would be very helpful in patients with PPMS.
Great, thank you. Question here?
I think you spoke about biosimilars.
Mm-hmm.
And my question is that when something is approved and it is a biosimilar, will the same precautions be taken as the brand drug? For example, if Tysabri were to have a biosimilar, and right now people are scheduled for frequent JC virus antibody testing, will that be part of the biosimilar procedure as well?
Yes. So with our current generics and bioequivalent and possibly a biosimilar coming up, our protocols and guidelines will remain the same. So clinically, we treat patients and these therapies the exact same way. So the monitoring that is necessary for the brand medication is also necessary for generics, biosimilars, and bioequivalents. Whether or not those services, depending on what is needed, is covered by the generic manufacturers, that's a different question. But yes, from a clinical standpoint, we will require the exact same monitoring that we do for branded medication.
Going further with that question, will this specific biosimilar manufacturer have the same test that is offered by the brand manufacturer?
That is a great question for Biogen. No, so the JC virus, as you know, is given through Quest Diagnostics, but it is funded, the test is funded but for most people by Biogen. At this point, I am going to treat my patients the exact same, whether they're on a biosimilar or not, and I'm going to order the test. Who knows how it gets paid for in the end?
Okay, thank you. Next question.
Is MS, hereditary? So if a father has it, can they pass to a child?
So there is a genetic component to multiple sclerosis. In those patients who have a first-degree relative, their risk of developing multiple sclerosis is much higher than what we would see in the general population risk. But when we look at identical twins or monozygotic twins, from the data that we know is that if one twin has it, the likelihood that the other twin will have it is only around 30 to 35%. So genetics is not the complete story, right? They share most of their same genes, and so it goes beyond genetics and takes into account potential environmental factors, exposure to viruses, particularly the Epstein-Barr virus, that increases the chances of the risk. So what I tell patients is you don't pass it down like you do your height or your eye color, but the risk is higher than the general population who doesn't have it.
Thank you. Next one from online. What alternative solutions are there to decrease symptoms?
I'm assuming that the question is referencing non-conventional or alternative treatments, and so we're talking non-pharmaceutical options. I did mention in the spasticity slides that there is some role for the treatment with cannabinoids or medical marijuana, for the management of spasticity and pain, although there aren't any clinical studies in the United States that supports its use. There are some studies looking at manufactured cannabinoids in the European countries that do show some benefit with some additional potential side effects, such as cognitive difficulties and fatigue. There are other things and modalities, and I think Jeff is going to highlight that as well, with really the use of physical therapy, exercises, and things that will help with, again, decreasing your tone and your pain, improving your fatigue. So there are a lot of different ways and other lifestyle modifications that we can do to improve symptoms.
Okay, thank you. I'm coming up to this gentleman over here. I don't know if his wife says that.
Has stem cell therapy ever been considered for like nerve regeneration or even remyelinization?
Yes. So there is some ongoing studies that look at it at its impact in the treatment of multiple sclerosis. I think, though, we are still very early on in the role of it helping to promote remyelination. Currently, a lot of the study around stem cell transplant is with autologous stem cells. So it is actually meant to help to replace your immune system. So our current goal is to help to create cells that won't attack the nervous system. The studies and the science behind promoting remyelination is still very early and in animal models.
All right, next question's here.
Can you be diagnosed with MS and then not be diagnosed with MS?
Yes, you can. And that is primarily because we don't have one clear diagnostic tool to say that someone has multiple sclerosis. And so to make the diagnosis of MS, it requires a clinical diagnosis, clinical presentation and symptoms, and then we also utilize MRI and spinal fluid to help to aid the diagnosis. But it would make my life easier if everyone fit in all the boxes and checked all the things that I need to check, but sometimes you don't. And so what we do as clinicians is we try to put the entire picture together to come up with the most likely diagnosis. And sometimes over time, as things evolve, as things change, as our technology evolves and changes, then we're able to get a clearer picture and then maybe determine that you don't have MS.
So what would be the procedure or the process of going through to get to a foregone conclusion whether you actually have it or have had it? I was diagnosed with it. I've been taking off medication. I believe I've been off for maybe about 3 or 4 years now since I've been down here. And so basically I'm not on any medication at all, but when they told me I didn't have it, and I keep hearing that it's a possibility I never had it, it's a, why did I stay on medication for so long, and now I'm just finding it out.
That's a complex situation, which will probably require a complex answer that I can't provide today without knowing the details. But I will, again, highlight that there are a lot of different features that we look for MS, and we try to come up with our best diagnosis, but as humans and error that we have, sometimes we are wrong.
Are there any specific diseases other than when somebody is misdiagnosed? Is there anything specific that it could have been?
Yes, so probably the most common misdiagnosis is neuromyelitis optica. So in patients who have NMO, they may present with optic neuritis. They may also present with inflammation of the spinal cord or transverse myelitis. And sometimes they can have abnormalities on their brain MRI. So as you think about what I just said, optic neuritis, spinal cord involvement, that sounds a lot like MS. But patients with NMO, their spinal cord involvement is much more extensive. And for that disease, we actually actually do have a blood test that is fairly sensitive to pick up that diagnosis. So NMO is probably the most misdiagnosis of MS, as well as isolated transverse myelitis. So someone can have an isolated event to their spinal cord without any subsequent symptoms or events, and that's not necessarily MS. Same thing with optic neuritis.
Okay, thank you for that answer. And next from online, we have what is happening when the body gets progressively more and more intense electrical shocks? What can be done to eliminate or reduce that kind of pain?
So those electrical shocks are very similar to that Lermite's phenomenon. So you have irritated nerve cells, most likely they're in the spinal cord, that are sending out nerve signaling. So that's that neurogenic pain I talked about. And so looking at the treatment options for that, most commonly we try the anticonvulsant medications. You're all familiar with gabapentin and Lyrica. But then again, avoiding triggers that make it worse, whether it's position, overheating, and then trying to, again, stay moving. So there are pharmaceutical ways that we can treat it, but there are other lifestyle modifications as well.
Okay, thank you. Next one is asking what biomarkers are used to determine MS progression?
So there are a lot of biomarkers that are evolving to kind of help us paint the picture of disease activity, even though they may not be as specific to multiple sclerosis. So one that is probably much more along in the advancement is neurofilament light chain. And so there is some studies looking at NFL in the spinal fluid. There are also newer markers in the blood that we can help to look to see if there's a correlation with disease activity. Not just progression, but also maybe preventing or showing looming or upcoming relapses. And so neurofilament light chain is probably the closest to being regularly used in the community, but there are others that are in development as well.
Thank you. I'll be there in a moment. My body doesn't want to run over there right now. I'm having leg issues. All right, so the person is asking that they've had problems with certain fumarates, and they want to know, they said that they heard about a new fumarate that's out, but don't know what it is, so can you just make mention of it?
I'm assuming that the new fumarate that they're talking about is bafratam or monomethylfumarate. And it has a mechanism of action that's very similar to the other fumarates by working on the NRF2 pathway. There is some thought that the monomethyl, the chemical structure may help to prevent some of the GI symptoms that can be seen with dimethylfumarate. I'm not quite sure if there's anything beyond bafratam.
I don't think so. I think that that's what they were mentioning as well, because they brought up Tecfidera and then brought up the newest one.
Okay.
Okay, thank you for that. All right, let's take a question from here.
From what I understand, Lermite's basically attacks the spinal cord where you receive pain and shock down your spinal cord. Can Lermite's also present itself in the side of your neck and in the shoulder, or is that a different?
Yes, so it depends on where the lesion is in the spinal cord. So if you have a high spinal cord lesion that is heading down to supply sensation to the shoulder and the neck, it can produce pain there.
For a person that's over 60 and is not on a DMT and knows that they're getting worse and not able to get onto a therapy, what are your best recommendations for these people?
So that is describing more secondary progressive MS. So I mentioned that the disease-modifying therapies are approved for patients who have active active secondary progressive MS. These are patients that have slow progression over time, as that was described in the question, but they have activity. And those patients who have MRI activity or small relapses, maybe reinitiating a disease-modifying therapy may be the option. But in someone that has inactive or non-active secondary progressive MS, where there isn't any clinical or radiological activity, it really goes down to some of our lifestyle and wellness modifications. So we are looking at doing physical therapy to help to continue with mobility. We're managing spasticity and pain. We're managing the bladder. All of those things to help to improve the quality of life in patients who are, unfortunately, who have secondary progressive disease.
Okay, specifically speaking, are people progressively getting worse if they have relapses?
Yes. So there is oftentimes a combination of both. So we talk about relapsing remitting disease, and we talk about secondary progressive disease, but they really are existing together on a continuum. And at any point in time, in any individual, there may be a more predominant relapsing component, or there may be a predominant progressive component. So it is felt that progression actually begins at the beginning of the disease, okay? And so you can have progression despite relapses, but you can also have progression because of relapses. So with each relapse, there is ability of accumulating new disability.
Okay, thank you. 2 more questions for you from this list, then I have to check back online again. All right, and that is, how long is too long to be on a medication?
As long as you're tolerating the medication, as long as you're seeing clinical benefit, there's never an end date for the use of a disease-modifying therapy. Again, it boils back down to my risk-benefit ratio. As long as the benefits outweigh the risk, I think it's something that you should continue to do.
Okay, and the last question from my hand of notes is to please explain the MS hug.
Yes, so the MS hug comes from oftentimes a spinal cord lesion, and it causes muscle spasms. But instead of the muscle spasms being in an arm or a leg, it involves the musculature around the rib cage. And so as those muscles spasm, they squeeze and give you that sensation of the hug. So we treat MS hugs like we treat muscle spasms in the limbs. If it's medication, stretching, making sure you're staying hydrated are the best ways to treat spasticity and muscle spasms in general, but that MS hug is just that.
Okay, thank you. Few questions from currently online, and that is, first one is, do you have any patients using the baclofen pump, and how are they doing?
Yes, I do have patients who use baclofen pumps. And again, there's an individual response, and I think we heard earlier today of one person's experience with the baclofen pump. But in those patients who have shown that they would benefit through that trial that I talked about, then they would be a candidate, and they are doing well. Not every therapy is 100% as we think about our disease-modifying therapies and our other symptomatic therapies, but definitely an option if you have severe spasticity.
Great, thank you. For everybody that's online and asked a question a certain way, like it had to do about you, well, we can't ask questions about you directly, so I've always reworded it to just be a little bit something more general, and that's why you may not have heard it exactly, okay? Because the doctor can't answer about you. Even if you were her patient, that would be giving up HIPAA rights. Okay, so there's a person here that's asking about, well, she just left when she heard that. How about that? So we'll go on to the next person. Ooh, there you go. All right, my MRI shows no change. All right, this person's MRI shows no change for 2 years, but there's differences and worsening in the walking. Anything that you could suggest for walking?
So I will answer two parts of that question. The first question I heard is, why am I progressing even though my MRI is stable? And the MRI correlates very highly with inflammatory disease or activity, relapses. It does not necessarily, though, correlate very well with disability progression and the neurodegenerative aspect of the disease. So there is neurodegeneration that is occurring on a microscopic level. It involves not just lesions, but brain volume that contribute to it. And it also involves the spinal cord atrophy. So just like we think about the brain shrinking, the spinal cord can shrink as well. And that is really what contributes to loss of mobility over time. But the MRI is not sensitive enough to pick up those changes. It's really good at new lesions, relapses, inflammatory activity, not as good as picking up neurodegeneration. But if you do have increasing mobility issues, the goal is to keep moving as much as possible. So I stress physical therapy, because that is what's going to help for you to maintain your function.
Okay, thank you for that. Stephanie wants to know if you could please explain to everybody what case management and nursing services are used for.
Yes, so case management services are used to help you to get the resources that you need inside of your home. So as your physician, I'm there to help to provide guidance, but it's the case managers that actually do the legwork to get those resources that you need. Nursing management as well. This is oftentimes, though, combined with home health services, right? So you have the home health nurse that comes out and does a safety evaluation, make sure that you're taking your medications appropriately, and that you have all the needs that you have. So those are extended services beyond what your actual neurologist or nurse practitioner can provide.
Being that MS is autoimmune disease, is there? I was also diagnosed with Bell palsy. Are there similarities between that and also some other autoimmune disease? Because from when I was reading about all this different stuff, when I first found out I had MS, there's a if I'm saying correct, a correlation with all the autoimmune disease symptoms coincide with each other. So how are doctors or yourself able to recognize what's what?
So you are correct. And autoimmune diseases do share some similar features. But what we have tried to develop over time are diagnostic criteria to help us distinguish it. There is some thought that if you have one autoimmune disease, you're at increased risk for having other autoimmune diseases, and sometimes those symptoms can overlap. But there are sometimes, for non-MS autoimmune diseases, serological or blood markers that help us distinguish that. So if you have, let's say, lupus, that can sometimes look like MS symptoms with numbness, tingling, there are blood tests that we can do for lupus to either rule that in or rule it out. So there's different features that we look for to help us distinguish between the autoimmune diseases, and when there are serological or blood biomarkers that we can use, we use those too.
Okay, the second to last question is going to be from the back of the room. Then I'm going to get this gentleman up front again, and then we're going to let you go home, okay?
All right, so I know DMTs are on the market to reduce the activity of MS in individuals, whether it's relapses or the other types of MS. Do you see in practice, I mean, there's differences in practice than in writing, but in practice, do you see a longer time period between a relapsing case of MS going into a secondary progressive case because of these meds, or a reduction in people going into secondary progression?
So it's hard to see that 30,000-foot view within the forest. But what I can say about my clinical practice and the patients that I see, although I will tell you I've only been in practice for about 12 years, so well under that 30-year mark. So most of the patients that I do see are treated patients. But yes, I do think that we are delaying and sometimes preventing that transition into secondary progressive MS, or I'd like to hope to think we are.
Last question.
Is there blood work whenever a person get blood work done? Is there any way to get blood work for all the autoimmune disease taking place at one time so that it can be diagnosed correctly or incorrectly? Or I guess if I'm saying correctly.
Right. So generally in my diagnosing phase of MS, when I am looking at a patient and I'm looking at could this be MS, I am routinely doing blood work to look for those other markers of diseases that could potentially mimic MS. So generally that should be done during that initial evaluation period, or at least that's my practice.
Okay, thank you very much for
Thank you.
spending all this time. All right, thank you again for coming today. I want to thank everybody online as well. Thank you all. Have a great day. Good night.